Hello, everyone. I'm Dr. Rita Roy, CEO of the National Spine Health Foundation. Welcome to Spine Talks, where we bring unparalleled access to world-class experts like the doctors who are joining me on the panel today. I'm really honored to be at the Cervical Spine Research Society meeting, where the experts are talking about neck conditions and problems that affect your neck. And so today, I'm going to start by allowing our experts to introduce themselves, and I'm going to turn it over to Dr. Gogawala.
My name is Zoe Gogawala. I'm chair of neurosurgery at Leahy Clinic and professor of neurosurgery at Tufts University Medical School.
Thank you, Zoe. Dr. Albert?
Hi, I'm Todd Albert. I'm Surgeon Chief Emeritus at Hospital for Special Surgery in New York and a spine surgeon. I had the privilege of being president of this society, the Cervical Spine Research Society, a number of years ago.
Thank you. Dr. Mraz?
Hi, it's a pleasure to be here. My name is Tom Mraz. I'm the global chair for the Cleveland Clinic organization, which includes London, all of North America. I'm also leading the spine research group, and I'm a spine surgeon by training.
Thank you, Dr. Mraz. Dr. Patel?
Yeah, my name is Alpesh Patel. I'm a vice chair of orthopedic surgery at Northwestern. I lead our Center for Spine Health, and I'm excitedly the current president of the Cervical Spine Research Society.
Thank you. So our distinguished panelists are here to talk with the public about conditions that impact your neck. There are lots of different reasons why those conditions happen, and there are lots of different approaches to treating those conditions. So I'm going to start it off with the current president of our society, Dr. Patel. Dr. Patel, a lot of people are confused about symptoms that affect their arm, and they don't know that arm pain or shoulder pain might be coming from their neck. Can you talk to us a little bit about that?
Yeah, that's actually a really common scenario. And we will see patients week in and week out who have been struggling with arm pain, shoulder pain, numbness, tingling in their arm, not realizing that it may be emanating or starting in their neck or in their cervical spine. And the connection there really comes back down to the nervous system and how we're wired, such that the nerves that supply feeling and sensation to the arm are in the neck. And so oftentimes we have to look there for the problem.
Dr. Gogawala, I've read some recent studies that you've published about the language around describing this kind of pain that patients feel in their arm that actually comes from the neck. Can you talk to us a little bit about some of that work?
Sure. I think it's so important for patients to understand that the symptoms that they experience are different in different people. And some people describe this as a burning pain. Some people describe it as a sharp pain. Some people describe it as an electrical sensation going down their arm. Some people have it more when they move their neck or they bend their neck in certain ways. And other people, it's just unpredictable. And fundamentally, I think for most patients, you just need to get a good physical examination from an orthopedic surgeon or a spine surgeon to determine whether, in fact, the symptoms that you're feeling are coming from your neck or not, because many of those symptoms might not necessarily be coming from your neck, but with a good physical examination, most orthopedic surgeons and spine specialists can figure that out for you.
That's great. And just to follow up on some of those comments, Dr. Gogawala, I'm going to ask Dr. Albert to comment. Dr. Albert is a past president of the society focused on neck conditions. Dr. Albert, as Dr. Gogawala is pointing out, getting a good physical exam to determine the source of that pain that patients sometimes feel in their shoulders or their arms, who should they go to? Who should they go to see? And, what type of practitioner can help them figure out the source of that pain?
Well, it's a great question. And what we hope or would aspire to say is that your family physician, a good medical practitioner, or a non-operative spine specialist, called a physiatrist, anyone, or an orthopedic surgeon or a neurosurgeon should be able to do a good physical examination. And I think what Dr. Gogawala was referring to is once we do a good physical examination, we can tell if they have weakness or sensory changes or reflex changes, banging on different reflexes, to say it's coming from this nerve or that nerve if it's pain in their arm. Or including in that exam might be a good shoulder exam to say it's your shoulder or it's a problem with your hand. You've heard of carpal tunnel syndrome or one of those things. And so really any orthopedic, neurosurgeon, physiatrist, and truthfully, family physicians or medical practitioners who are their family doctor should be able to perform that position. That's at least what we hope for in medical education.
Yeah, that's amazing. I'm going to ask Dr. Mraz, as the global chair for orthopedics with the Cleveland Clinic, I'm sure you see a lot of these conditions and collaboration amongst different practitioners in the Cleveland Clinic. So if a patient goes to see a primary care doctor and they think they've got bursitis in their shoulder, but a neurologic exam is done and the family physician thinks it might be actually a nerve problem coming from their neck. What does that series of steps look like? How do patients move between a primary care doctor and a specialist?
It's a great question, and it's going to vary from organization to organization. But at the Cleveland Clinic, we have something called care paths, which are digital imprinted pathways that a person or a patient will be put onto if they have a cervical radiculopathy, regardless of where they enter the system. It's not only at the Cleveland Clinic. I'm sure other large organizations have this, but it allows a patient to be treated the same way. And so through the standardization, we're able to affect the right outcome that we're looking for. But the good news is that the majority of patients who have a radiculopathy don't need to see a surgeon. The majority of patients, thankfully, are going to get better with non-operative care.
Dr. Mraz, can you explain to us what you mean when you say radiculopathy?
Sure. Radiculopathy just means, in lay terms, a pinched nerve, an irritated nerve root. The nerve roots come off of the spinal cord, and just as Dr. Albert said, they traditionally follow a pathway down the arm. And so, and as Dr. Gogawala said and alluded to, it's really important for the clinician to take a really comprehensive history. Usually, we're able to determine whether or not it's coming from the neck or somewhere in the arm in the form of a peripheral nerve entrapment syndrome. By way of history, and certainly as we couple that with a physical examination, we're typically able to determine where the patient's pain is coming from.
So we've been talking about pain as a symptom that would bring people to see a spine expert to determine the source of that pain. Let's talk a little bit about causes of that pain. What are some of the conditions that lead to a situation where a patient is experiencing pain? Dr. Gu, I'll pass that over to you to start.
Sure. I think that there are a lot of different things if we're talking about pain that's coming from the neck and going into the arm. A patient could have a disc herniation in their neck. A patient could have a bone spur in their neck. A patient could just have an irritated nerve that's going through a narrowed space coming out of the spinal column. There's a whole host of things that can cause the same types of symptoms in patients, but they mean different things to specialists in terms of, what the next steps should look like.
I love this idea of hearing from our experts in their own words about the different conditions in the neck. Todd, talk to us about how you describe some of the kinds of problems that you see in the neck that result in radiculopathy or pain, nerve pain.
All right. So the first thing to know is generally, most of these things are normal aging process and not, quote, disease. We always, when we do a history on a patient, want to make sure they don't have something we call red flags coming from, and this is rare, but this is the one thing you don't want to just send the patient out, take 2 aspirin and go home. If they have night pain, if they have fevers or sweats that could imply they have an infection or a tumor or something like that, which would put you on a different pathway, meaning that's the patient who gets an MRI. One of the problems in our country is overutilization of things where people have a little neck pain for a day and they get an MRI. That's not appropriate. That's not appropriate. They need to have, as Dr. Gogawala said, an exam and an initial diagnosis and a treatment. And the other thing to say is most of these things get better almost no matter what we do, and very few patients need surgery for this. So that's important. But in terms of what are the initial things that could cause it, it's an age-related problem. It could be arthritis in the neck or what we call spondylosis, spurs that cause a narrowing or pinching of a nerve. It could be a herniated disc, which is more common in the 40-year-old to 55-year-old patient, a younger type of neck. And if you're like 65 and herniated disc, congratulations, you have a disease that's of a little younger person. And then as you get older, you can have those problems too. And the other thing that we see, that every one of the four of us, I guarantee, if you went and measured the spinal canal diameters of the majority of patients in our clinic, they are smaller. People have different sizes and shapes of spinal canals, just like they're different sizes and shapes of people. And we've never done this study, which should be done. And if anybody's going to do it, I would say Dr. Gogolwala would be the one to do it, since he's an amazing researcher. But if we look at all of our clinics and compare them to the normal population, I can almost guarantee you, without proving it, that the people that enter there have a little smaller spinal canal because they have less additional room when they have these spurs and bumps in their neck before they get those irritations.
More likely to experience a problem. Yeah.
So, really good. To just add one point, I agree with Dr. Albert very much about the overutilization of MRI to try to make diagnoses for patients. And I just wanted to add one thing to that. A lot of patients today will get an MRI and then they'll get a report that comes on their health portal because we want to have patients to have access to all of their health information. But for most people, they're really scared when they see their MRI report because the normal process of aging is often dictated in that report, and it makes it sound like they have a lot of problems that might not be causing any symptoms at all. So my point in saying that is that I think we've got to recognize that all of us, as we get older, develop some arthritis. All of us will get some changes in our bones that might not necessarily mean that we have a problem with our spinal cord or have a problem with one of our nerves. And to Dr. Albert's point, depending upon what the size of your spinal canal is, you can tolerate a lot of different degenerative changes in your neck without having any problems for your nerves. But I think it's so important for patients to recognize that getting that physical examination, whether it's with your primary care doctor, a nurse practitioner, an orthopedic surgeon, a neurosurgeon, is very, very important in getting this evaluated as opposed to just jumping to that MRI.
I think if I build up that a little bit more, I would agree that, we have these amazing technologies available to us, right? Diagnostic imaging, MRIs, CTs, special x-rays. We have a lot of these tools available to us, and they're wonderful when needed. But a really good history, like listening to what Tom was saying, listening to the patient, listening to their story, asking some of these key questions like Dr. Albert had mentioned, and then combining that with the exam, that'll typically get us 80 plus, 90 plus % of the way towards the diagnosis, and certainly enough to initiate treatment. Then the diagnostic imaging comes into play when we're trying to get to maybe more of the heart, related to your question about what are the things that are causing it. Is this a disc problem? Is it a bone spur problem? That's the right sequence. I wish I could say we always do it that way.
Yeah.
Oftentimes it's inverted. Where the MRI is obtained, the x-rays are gotten, all the advanced imaging is available, and then we go back and we ask questions about the history.
Yeah.
And to Zoe's point, a lot of the byproduct of the imaging we do creates noise. It's noise in the system. It's not actually signal, and it does create a lot of stress, anxiety, and frustration. And I'm sure all four of us spend a fair amount of our time in the office dissecting down and translating an MRI report from radiologist to English, right? We spend a lot of time doing that.
We have a saying in the National Spine Health Foundation that degenerative changes are a normal part of aging to your spine, your cervical spine, your lumbar spine, but pain doesn't have to be. And so it's interesting. We also hear experts telling us that if you pull somebody off the street and you x-rayed them, and you looked at their spine, 80% of people will have some changes there that are completely asymptomatic. So that idea that you can't unsee that, right? So then once you see it, to your point, Dr. Gogolwala, it becomes scary, like, oh, I didn't know I had this thing. And the fact of the matter is that a lot of times you can have things that are asymptomatic and not problematic. The pain is a message to your body that there's something more going on that might need treatment. I'd like to talk a little bit specifically about degenerative disc disease in the neck. A lot of people use the term a slip disc, a herniated disc. Does that mean the same thing? Let's talk about what a slip disc is or what a herniated disc is, and how patients feel with that and how you approach treatment on that.
This is a common question that we get, and I'll go back to what Dr. Albert said before. The word spondylosis just means disc degeneration, and you can't get through life without having some degree of disc degeneration. And at a molecular level, there are changes that we all, as physicians, understand occur, and over time, that disc starts to look differently on an X-ray, and it looks differently on an MRI. And if you think about it on a spectrum, first, the color of the disc changes, and then the disc height changes, all referring to disc degeneration. Sometimes we get bone spurs. Again, these are all normal parts of aging. And so, disc degeneration is really an umbrella term that encompasses a spectrum of things, of radiographic changes that occur over the course of one's life, but they are in no way a disease. And I try to emphasize that to a patient. Listen, you do not have a disease. This is a common thing. And in fact, at my age, if I had an X-ray of my spine, I'm sure that I would have some degree of disc degeneration or spondylosis. But hopefully I won't become symptomatic to a point where I need one of these people to work on me.
We're available if you do need it.
Do you have a special way, Dr. Albert, that you talk about degenerative disc conditions with your patients in explaining that?
So what I say to them is not different from what Tom just said. I said, you should look at this as if, and I'm sure if it's a woman, I would say, I know you don't have any, but it's like having gray hair or a bald head. Be lucky you don't have a bald head. It'd be just again. It is just normal. It is just normal. And your pain may be coming from this, but exactly as was said, it's not a disease. Mm-hmm. I say it's just a part of aging.
So with degenerative disc changes, a normal part of aging, when is it time to get treated for those conditions? Let's talk about that, Dr. Patel.
Yeah, I think, it does, we use that word degenerative, and yet we also say it's normal. And I think that's a sense that creates some tension or conflict as patients try to sort their way through this, right? Because degenerative in their mind, I think, in many people's minds means somehow a disease process, it's progressive, it's irreversible. And I think a lot of patients have stories themselves, their family members, their friends who have suffered from lower back or from chronic neck pain issues, chronic lower back pain issues, and have given that diagnosis of degenerative disc disease, right? So to answer your question, when do you seek treatment? It's probably more symptom-driven treatment as opposed to a firm diagnosis, right? As Tom mentioned, you may have degenerative disc disease in your neck, you may have degenerative disc disease in your lower back, and have very little to no symptoms for it, in which case less is more. You need less treatment. You need to be encouraged to live your life, be active. But I think as soon as somebody's developing symptoms, we try to intervene. I'd be curious from the group what your most common interventions are. My most common conversation with patients after spending a lot of time counseling them that these are normal things to go through. I feel bad they're going through it, but it's normal. Then the conversations oftentimes come down to, what's your diet look like? What's your exercise look like? Are you willing to stop smoking? Right? Because there are things that you can control.
Yeah.
And then there are things, aging, genetics, family history, that you can't control. So I try to focus on the things you can control.
Right. Yeah, that's amazing. How long should patients go with pain? Do you just put up with the pain, or, you take over-the-counter medications, you go see a chiropractor or a massage therapist? If you've got pain going on, how long should that last before you might need further treatment? Who would like to tackle that?
I can take that. I can try to. It depends on what type of pain we're talking about. And neck pain is very different than arm pain. That's oftentimes different than pain that comes over to the shoulder blade region and the trapezial region. But if we're just talking about axial neck pain, which is dead center in your neck, it's worse with mechanical activity, sometimes better when you wake up, and throughout the day it starts to get worse, sort of like a shoulder or a knee or a hip. That is typically arthritic type of pain. And the majority of human beings do not, even though they have arthritis or degenerative changes on their x-rays or the MRI, they don't develop chronic neck pain. The majority of people will at some point in their life have an episode of neck pain, but typically it will get better. But if we're just talking about neck pain, then I think, as Alpesh appropriately discussed, healthy diet, lots of physical therapy, and activity on a daily basis. And I said lots of physical therapy. If they're not getting better, then I'll send them to a course of physical therapy. But patients can't go to physical therapy forever, and it really is based upon an incorporation of the exercises that one learns in physical therapy and does it daily. I'm a big proponent of the merits of exercise on a daily basis, eating right. And as physicians, I think there's a lot that we can do to make sure that we harmonize our approach with what's happening in the rest of the medical record, with our internal medicine folks, what's happening in the labs, because it's all interrelated. So we try to take a comprehensive approach, and that's why, most spine programs across the country have a large contingent of medical spine specialists, in addition to colleagues that treat the internal medicine issues. But comprehensively, I think addressing an episode of neck pain or a chronicity of neck pain in a very holistic manner is the right way to do. But usually it's not a chronic issue. Now, we talk about arm pain. It's a very different story. There are different echelons of care that we send a patient down to. It's probably a separate question, so I'll stop there and we'll just leave it at neck pain.
I was brilliant what you said, and it's so true. But a lot of people I see, when they have neck pain, no matter what, whether it was started a little traumatically from a fender bender or it's spondylosis, they have this episode of neck pain. And when you get pain in your neck, it shuts off your muscles. And so they get a secondary problem where, depending on their initial treatment, if they just weren't taught, and he made me think of it when he said exercise, they just weren't taught to do strengthening, simple strengthening exercise, either isometric, which means not moving while you just strengthen the different components of your neck musculature. They can get into this vicious cycle where their neck muscles are weak, so they get more pain, and they don't, and then they get weaker, and they get weaker, and so one of the initial things I always think to do, and I'd love to have other people's opinion about this, is just say, you need to reverse this. You need to start doing strengthening exercises, with or without a therapist, because a lot of people focus on your flexibility, and I would say, get yourself in shape, cardiovascular shape, aerobically, and do these strengthening exercises, and you can reverse a lot of things. Or I don't know what others think.
Well, and one of the big things I'm hearing today is that the physical therapist or practitioner you go to your appointment and they give you exercises, do the exercises. Mm-hmm. You don't just show up for the physical therapy appointment and then you did it, right? They're there to guide you.
I think patients and folks suffering with neck pain going through therapy go one level deeper, which is to not just be passive participants in their therapy, but really to take some ownership and some engagement and some active work in it. So I've seen patients who are diligent, wonderfully, they go to their therapist twice a week, and then the other 5 days a week, they're busy with life. They've got other things to do. And not surprisingly, that individual's run of symptoms is going to go longer. They're going to have symptoms for a longer period of time. So really owning it, but then also it's a fair question to ask us as specialists, to ask therapists, why is this exercise going to help?
Yeah.
Right? Because I think if people start to understand the why and the how, they're more likely to actually maintain the exercises themselves.
Right.
I just have one thing. I think what Alpesh said is absolutely correct. But I think it's also important that patients understand that in order to do the right muscle stretching exercises or strengthening exercises, as Dr. Albert has mentioned, these are not things that you just go to the internet and download and start doing it yourselves. I think that it's really important to see either a physiatrist or a spine specialist, get proper physical examination done, figure out what the problem is, and then have a program that's really tailored to your problem. And another part of that is that not everything works for every single patient. Physical therapy might just not work for some patients. And a lot of us, use acupuncture therapy, use massage therapy, and there's a whole host of non-operative treatment options that can work for different patients. But I think it's got to be coordinated by a physician at some level so that we're treating the fundamental problem.
So we've been talking about neck problems, how you diagnose them, what they feel like, how do you know when you need to see a specialist, what kinds of treatments, how do you approach treatment. Now let's have a discussion about some of the surgical treatments for these conditions. When is it the right time to have surgery, and what kind of surgeries are out there?
I think that's a great point. And it's probably really important to start first and foremost understanding why is it that someone needs surgery. As we mentioned earlier, very few people with neck conditions end up having an operation. So we are very selective about who needs surgery so that we get the best results, right? We start off by saying, again, what is your symptom pattern? So individuals who have neck and arm symptoms, so pain down the arm, numbness, tingling, weakness, those individuals, when it comes time for surgical management, actually have very high success rates, right? With lots of different surgical procedures. And we'll get into the different procedures. When it's just neck pain alone without neurological involvement, the results of surgery can be quite mixed. And I think many of us here would agree that that's an area where, as a surgeon, as a patient, we proceed towards surgery with a lot of caution.
And what is that kind of condition called when it's just neck pain?
Yep. So there's lots of different words for it again. And so patients may be given diagnoses like cervical spondylosis. They may have a diagnosis even of what's called cervical stenosis. So they may have narrowing around the nerves or even narrowing around the spinal cord, but all they have from a symptom standpoint is neck pain. So when I talk to my patients about it, I try to simplify a lot of that noise.
Right.
And I try to just go, again, based on symptoms. So if they have neck pain only, I tell them that their diagnosis is neck pain.
Mm-hmm. Dr. Mraz, we were chatting before about two medical words, myelopathy and radiculopathy. National Spine Health Foundation has a spine glossary that defines all these terms. You can find that at spinehealth.org. But could you tell us in your words the difference between those two and how that factors into a treatment pathway?
Absolutely. As it pertains to the cervical spine, most things that we care about are a radiculopathy, which is a pinched nerve, as Alpesh just mentioned. That's numbness, tingling, pain, plus or minus weakness that can occur typically on one side and one arm. And that's due to nerve root compression. As I mentioned, the nerve roots come off the spinal cord at every single level, and both in the left and the right side. Spinal cord dysfunction is an entirely different problem for the patients. When the spinal cord gets compressed, and it can be compressed by a variety of different things, the two most common things would be just run-of-the-mill arthritis. So as we get older, and as Dr. Albert said, our canals vary from person to person in terms of the dimensions. And sometimes when the spinal cord becomes compressed, that could be due to enlargement of an important ligament in the back of the spinal cord, or it can be a disc bulge in front of the spinal cord. But when the spinal cord's compressed, it can at times start to malfunction. And we see that malfunction as people as loss of hand dexterity, different patterns of numbness, most commonly in the hands. Sometimes we start to lose our balance. That is a very different problem with different implications compared to a nerve root or an arm-related problem. And we treat it entirely different.
As doctors who treat patients with neck problems, the difference between the spinal cord compression and a nerve compression is important in a lot of different ways. But one of the most important, I think, is that if you have spinal cord compression, you may have no neck pain at all. And a lot of patients have these symptoms that Dr. Mraz talked about of, coordination problems, difficulty writing, difficulty with buttons when you're getting dressed, difficulty with keys, these sorts of things, or an unsteadiness in your walking. And we talked earlier about a whole host of conservative approaches, physical therapy, exercises, acupuncture, and so forth. When there's spinal cord compression, by and large, there's not a large role for conservative management. If the spinal cord is compressed, that's when, generally speaking, you want to be moving towards surgery sooner rather than later. It's not necessarily an emergency, but you want that spinal cord to get decompressed so that it could become healthy again. And I think that's a difference between the neck pain coming down the arm and the spinal cord compression.
And can we qualify just to say it's spinal cord compression with symptoms?
With symptoms, yes.
With symptoms. I think it's a really important point you made. It's like, I would say it's an expediency. It may not be an emergency, but it's an expediency. For me, we look at it like for heart surgeons, which people think more about triple vessel disease when they're going to go and either get a stent or they're going to get a heart surgery. They may get that more emergently than we do myelopathy surgery. Myelopathy, remember, signs and symptoms of spinal cord compression. But it's different than a pinched nerve, and people need to understand that, I think.
Thank you. That's really helpful to understand the differences. It is so complicated. The anatomy is so complicated with the spinal cord being protected by your spine and those nerve roots coming out, emanating out, and controlling all of your body functions. So many ways that things can go wrong, but it's such a beautifully designed system in our bodies meant to move. Motion is lotion, right, for everything. Let's talk a little bit about artificial disc replacements. There is some confusion out there about what this technology is. Sometimes patients are confused about what artificial disc replacement technology is. Is it experimental? Is it available for everybody? And what is it used for? And I'll toss that over to you, Dr.
Yeah,
Patel.
I'll start by saying it. The good news is that it's not experimental, right? It is well established. There's actually lots of clinical trials demonstrating how effective disc replacements can be. I think it is also, though, that, again, to go deeper, it's not a universal fix either, right? There's a lot more information that we need, and I'm sure my colleagues here will talk about that, to try to figure out who's the right candidate, who's the right patient for a disc replacement, and then what's the right disc replacement for that patient. So I think there's a lot more information we need, but to answer your first question, not experimental, it is available. It is FDA approved.
Right.
And it's an exciting avenue of work that we're all heading into.
And a lot of patients are getting this treatment and doing extremely well with it. So given the information that is available and the FDA approval of these technologies, it is an option for certain patients. Dr. Gogawala, is this a technology that you use in your practice?
Yes, and I would say that, you said motion is lotion. I think most of us, as we move along in our practice, we don't know the exact type of patient in every scenario that's ideal for either the artificial disc or another motion preservation type of surgery. But I would say that in my practice, I am looking more and more to see how do I preserve motion when I treat a patient with a spinal cord or a nerve problem in their neck. Because the fusion, which is where you fix part of the spine together, the fusion operation is also very, very successful. But patients, by and large, if they are candidates for motion preservation, they do better in the long term. And so I'm trying to, in my practice, look to broaden the applications for these motion preservation techniques, whether it's arthroplasty, the artificial disc, or another operation that preserves motion called laminoplasty, which you do for the back of the neck.
Dr. Albert, do you see cervical disc replacement in your practice?
Yes. What I see is so many people on the other side of it, the patient come and they hear about it and they come and say, I want a cervical disc replacement. And the harder conversation is not like you're a perfect candidate, because we have many good candidates. We have still, as Zoe said, we still are defining who the right candidate. And when something gets released and there's an enthusiasm, and what I see are a lot of people that probably shouldn't have a disc replacement, if they have too much arthritis or spondylosis in their neck, or other reasons, or instability, that's not a correct patient for disc replacement. Yet they heard about it, I said, I want a disc replacement. And then you're in this conversation where you're saying, no, it really is. If you were my family member, I wouldn't recommend you have a disc replacement. So we have to help define and counsel patients that there are perfect patients for disc replacement, those patients with a beautiful, youthful looking neck, not much arthritis, herniated disc at one or two levels, perfect patient for disc replacement. Not the very arthritic patient, or what we call kyphotic, where their neck is bent the wrong way, or they have instability, or they have injury or fracture. Not the right patient. And so it'd be a bad operation. The device is great. We as surgeons and physicians have the responsibility to help define the perfect patients for it, the good patients for it, and what kind. There's now different types of disc replacements. How much constraint? How much does it move? How flexible is it? There'll be ultimately different disc replacements for different indications.
Dr. Mraz, your experience with artificial disc replacement in the neck.
Yeah, it's one thing that I think the community of spine surgeons have done right. We put a lot of effort in the appropriately designed studies to bring this technology to market. And right now, when we talk about cervical radiculopathy, we have three primary options, one of which is, as Alpesh mentioned, a posterior foraminotomy. Another one, as Zoe appropriately mentioned, is an anterior fusion. And finally, we have the disc replacement. And just like the panel has said, we have to appropriately match the patient to the right surgical technique and procedure. Ultimately, one of the goals obviously is to make patients better, but the ultimate is really a principal goal that we have is to make sure it's a durable outcome. And what we don't want to do, and I think Zoe alluded to this, is to do a procedure that can potentially lead to a problem. In the case of fusion, why this seems to be really an attractive option for us in this motion preservation is because when we do fuse a single segment of the spine, the level above or below can in fact break down. And we know that this happens in a certain percentage of patients at various time points following the surgery. And so I think the disc replacement technology or the motion sparing technology it's an attractive option right now. And I think over time, we're going to learn more and more and more and finally dial in the right implant for the right percent.
I'm gonna build on that and say that is a big driver, right? Patients will come, they're worried, and they hear stories that if I have one spine procedure, I'm going to automatically have another and another and another. I think we hear that in lower back conditions and in neck conditions, and that fear is a big driver for why people are looking for solutions. And disc replacements in the neck, motion preservation, if we focus on the anterior-based components, they came to market hoping to solve that problem. And there are some studies that suggest that for some patients, you can reduce the risk of that next level going out. I would maybe argue and say that that's not proven across all patients. We have a really hard time predicting who's going to have another disc problem and who's not. And to some degree, it's a bit of biology at play as well, right? Like we can't stop the aging process. So the conversation I oftentimes have with my patients when we're thinking about fusion versus disc replacement is a pro and con, right? We may have a potential benefit for you, but we may also see problems 10, 20 plus years down the road with the disc replacement. And oh, by the way, none of that stops the aging process. So the thing I tell them is that we can't make many guarantees in spine surgery, but I can guarantee that in 5 or 10 years, they're going to be 5 and 10 years older, right? And so will their discs. So I think we'd love to present it as this phenomenal solution for all patients. But again, the reality is that that's not where we're at.
Yeah. And I would just say another motion preservation procedure is a total knee or total hip replacement. But we need to start thinking, and patients should start thinking about it. When they have a disc replacement, it's almost like they had a right hip replacement. Well, the patient has a right hip replacement. When 3 years later, they come back with a left hip pain and need a left hip replacement, they don't blame the right hip replacement for the left hip replacement. But as spine surgeons, when they have a C5-6 disc replacement, which is not unlike a hip replacement, when they need a C4-5 disc replacement a few years later, somehow the 5-6 gets blamed for the 4-5, but it's not. It's an analogous situation. Just they're more their biology and their genetics. Yeah. And I always say to them, the reason you need that next surgery is the same reason you came for the first surgery. It's not the first surgery. It's the reason you came for the first surgery. That is most probably the reason for the second surgery.
Thank you for that explanation. This has been a fascinating conversation. I am so grateful to the panelists who have joined us today to tackle this very complicated and complex topic of neck problems. And what we've heard today is that there are many causes for neck problems. There are many solution pathways for neck problems. And what we try to do at the National Spine Health Foundation is give the public and give patients the best possible information they can find to educate themselves and to educate yourself on how to make a decision along with your healthcare provider on what is the right treatment option for you, because there are lots of options out there. And the other thing that our experts advise us is that it's fair game to get multiple opinions. Talk to more than one practitioner. That's okay. Nobody's going to be upset about that. That is a very welcome thing, I think, certainly amongst the spine community. Talk to more than one practitioner and make sure that you feel the most informed and most comfortable with the treatment pathway that ultimately you choose along with your surgeon or your provider, whether, that may be non-operative, that you feel empowered to make that decision for yourself. We feel very committed to providing those tools and this information, and that would not be possible without the support and input and expert insight from our illustrious panel that joined me today. So thank you very much to our panelists. We describe these surgeons as healthcare heroes who put the best of medical science into practice every day for their patients, and we thank them for that work. Thank you.
Thank you.